My name is Gabriel Cabanilla, and tonight I'm going to be talking about canagliflozin and the renal outcomes in type 2 diabetes and nephropathy. We should start with the definition. And what is canagliflozin? Well, it's a medicine that belongs to a new group of oral antidiabetics that exert their action by inhibiting the sodium glucose cotransporter type 2 of the renal proximal tubule, reducing the concentration of blood glucose, and it is indicated in adults with type 2 diabetes mellitus alone or in combination with other hypoglycemic agents. This video could explain it in a better way.
The development of diabetic nephropathy involves hypertension and hyperglycemia-induced changes in multiple pathways that contribute to morphological changes in the kidneys. The glomerulus is a globular-shaped structure composed of capillaries that are actively involved in the filtration of fluid from the blood to form urine. With diabetic nephropathy, early glomerular hemodynamic changes include hyperfiltration and hyperperfusion, which result in microalbuminuria. Increased afferent arteriole dilation due to a dysfunction in the vasoconstrictive autoregulatory response contributes to increased intraglomerular pressure, which is associated with greater mesangial cell matrix production. Expansion of the mesangial area, an early morphological change with diabetic nephropathy, is caused by greater extracellular matrix deposition and mesangial cell hypertrophy. This expansion is associated with a decreased glomerular filtration rate and a reduction in the surface area for filtration, which marks the beginning of renal failure. As this process continues, the glomerular basement membrane thickens, and this may eventually lead to glomerulosclerosis. All of these changes in glomerular hemodynamics cause stress and strain on the kidneys, which, if left untreated, may result in renal failure.
Well, knowing this, what are the applications in medicine for canagliflozin? And it is known that nowadays are being developed new treatments that can prevent or delay the progression of chronic kidney disease, also known as SGLT2, are drugs that improve the glycemic control in patients with diabetes mellitus type 2. At the moment, we can find in the market the empagliflozin, the canagliflozin, and the dapagliflozin. This video could also tell what I was been saying right now.
When your type 2 diabetes numbers aren't moving in the right direction, it can be a burden. What if you could wake up to lower blood sugar? Imagine loving your numbers. Discover once daily Invokana. With over 6 million prescriptions and counting, it's the #1 prescribed SGLT2 inhibitor that works to lower A1C. Invokana is used along with diet and exercise to significantly lower blood sugar in adults with type 2 diabetes. It's a once daily pill that works around the clock. Here's how. Invokana reduces the amount of sugar allowed back into the body through the kidneys and sends some sugar out through the process of urination. And while it's not for weight loss, it may help you lose weight. Invokana can cause important side effects, including dehydration, which may cause you to feel dizzy, faint, lightheaded, or weak, especially when you stand up. Other side effects may include kidney problems, genital yeast infections, urinary tract infections, changes in urination, high potassium in the blood, increases in cholesterol, or risk of bone fracture. Do not take Invokana if you have severe kidney problems or are on dialysis. Stop taking and call your doctor right away if you experience symptoms such as rash, swelling, or difficulty breathing or swallowing. Tell your doctor about any medical conditions, medications you are taking, and if you have kidney or liver problems. Using Invokana with a sulfonylurea or insulin may increase risk of low blood sugar. Imagine life with a lower A1C. Are you loving your numbers? There's only one Invokana. Ask your doctor about it by name.
Okay, in talking about pros and cons, we can find that it reduces the kidney disease, but in cons, we have death, myocardial infarction, stroke, hospitalization for heart failure, and we also can find other pros and cons that are the for talking about pros. We can find that it reduces cardiovascular events and it also reduces renal events. But in the other hand, we have that it can also increase the rate of amputation, and it can also increase fractures, genital infections, volume depletion, and ketoacidosis. So now talking about the issues that it will have in Ecuador, we have that in one investigation, 4,401 patients had undergone a randomization with a median follow-up of 2.62 years. The relative risk of the primary outcome was 30% lower in the canagliflozin group than in the placebo group, with event rates 43.2 and 61.2 per thousand patients a year, respectively. The relative risk of the renal-specific composite of end-stage kidney disease, a doubling of the creatinine level or death from renal causes was lower by 34%, and the relative risk of the end-stage kidney disease was lower by 32%. This is a video that can talk about it, so I'm gonna show you.
My colleagues Melanie Davis and Kamlesh Kunti and I have written a review in the journal Clinical Pharmacology Advances and Applications on what we should know about newer therapies when treating patients with type 2 diabetes and renal impairment. An estimated 200 million people worldwide have chronic kidney disease, mainly due to diabetes, arteriosclerosis, and hypertension. Approximately 40% of patients with diabetes go on to develop chronic kidney disease. We know from major randomized control trials that intensive management of glycemic control improves incidence and progression of chronic kidney disease. It is essential, therefore, to know how to combine both new and conventional glucose-lowering therapies in patients with type 2 diabetes safely and effectively. Our review focuses on the use of both conventional and newer glucose-lowering treatment in type 2 diabetes, clearly illustrating which agents require dose adjustment or discontinuation with worsening renal impairment. Table 3 shows which conventional therapies are safe to use as chronic kidney disease progresses. In Table 4, we have summarized how the newer treatments for type 2 diabetes, specifically DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors, can be used safely across the chronic kidney disease spectrum. The inclusion of several new glucose-lowering treatments increases the likelihood that type 2 diabetes will be well managed in the future. This should have a positive impact on long-term incidence and progression of renal impairment. Ongoing clinical studies of large populations with diabetes and chronic kidney disease, including studies such as CANVAS-R, CARMELINA and AWARD-7, will further determine the safety and efficacy of these newer agents and confirm if they have renoprotective effects. Thank you for listening.
With this in mind, we can conclude that depending on the undiagnosed cause, it is possible to treat some type of kidney disease. However, many times, chronic kidney disease has no cure. In general, treatment consists of measures to control the signs and symptoms, reduce complication, and delay disease progression. If your kidney manifests serious damage, you may need treatment for kidney disease ends. Thanks you for watching, and I'm glad that you like it.